Good afternoon, everyone, or good morning, I guess, depending where you are in the world. As Mel mentioned, my name is Dr. Sonia Mathler. I'm a family physician and also Parkinson's patient, having been diagnosed over 21 years ago, and I have the pleasure of being your moderator today. Parkinson's disease, as you know, is a pervasive illness. It doesn't just affect our physical health, but our emotional and mental health as well. The latter two areas of our well-being that are affected kind of fall within this category of non-motor symptoms. Non-motor symptoms encompass a long list of other things that this disease can cause, other than the motor stuff that we're all familiar with, the tremor, the stiffness, the slowness. It can encompass everything from skin changes to pain to constipation to urinary urgency. And then there are those non-motor symptoms that affect our emotional and mental health, mood or disorders such as depression, anxiety, psychosis, and cognitive decline such as mild cognitive impairment and Parkinson's dementia. We defined many of these issues in our last webinar with Dr. Daniel Weintraub, which can be accessed online through the website. But today we'll be taking a little bit more of a deep dive into these topics. We'll explore further how cognitive and mood disorders can affect those of us with PD, when to suspect confounding factors such as infections or medications that may be contributing to cognitive decline. We'll also go into greater detail about psychosis, how to manage it, and also something we really don't discuss enough, but which is really so important, and that's how care partners can manage their own stress when they have a loved one that's dealing with a mood disorder or cognitive issues. We're grateful to have with us today Dr. Jennifer Goldman. Dr. Goldman is Section Chief for Parkinson's Disease and Movement Disorders Rehabilitation at the Shirley Ryan Ability Lab and Professor of Physical Medicine and Rehabilitation at Northwestern University Feinberg School of Medicine. She's been a pioneer in the cognitive and behavioral aspects of Parkinson's and a long-standing champion of interdisciplinary care. Thank you so much, Dr. Goldman, for joining us today. So, let's start with a topic that we get lots of questions about, if you don't mind, and that's psychosis. As a reminder, sort of a refresher from our last webinar on the topic, could you please briefly describe what is meant by the term psychosis and how this manifests in someone with Parkinson's disease?
Sure. Thanks so much, Dr. Mather and Mel, for inviting me here to be on the webinar today, and really happy to be able to shed some insights on some of these important topics. And really dovetailing on the prior webinar with Dr. Weintraub and digging into psychosis a little bit more, just to refresh people or to inform people for the first time that psychosis really has a broad terminology and a broad, what we call phenomenology, meaning what it looks like and what types of symptoms it can involve. So we tend to lump a few things under the terminology psychosis. Most commonly, we think of hallucinations and delusions, but it's really even a broader spectrum than that. So people can have, even on its mildest forms, what we call illusions. And those are misperceptions of something that's really there in the environment, but the brain thinks it looks like something else or sounds like something else. There can be a sense of passage or sense of presence, where someone may feel something someone standing over their shoulder or fleeting by in the corner of their peripheral vision. Those tend to be short-lived and seconds long, but also can be a common feature under the umbrella of psychosis. We also see that people can have hallucinations, and those can take a couple different forms or sizes and shapes, if you will. So they can be visual, being the most common feature of hallucinations, which could be even patterns or dots or things in one's vision, all the way to more formed objects like people or children or animals scurrying around. They can also occur in other modalities. So we typically think about visual hallucinations, but we shouldn't forget that people may also experience hearing things that aren't there, like music or sounds, or smelling things that are not necessarily there in the environment. And the last aspect of psychosis falls under what we call delusions, which are less common but can occur as well. And those are what we term fixed and false beliefs. So thinking that something's really true when in actuality it's not really happening. More commonly, those take the flavor of things like suspiciousness or infidelity, and albeit less common than hallucinations or illusions, something we need to recognize as the whole spectrum of psychosis.
Right. So the hallucinations then, I guess, because some people get that mixed up, hallucinations versus delusions. So hallucinations is more the sensory, um, I guess, sensing that something's there or seeing something's there that isn't, and delusions more about thoughts. Is that correct?
Absolutely. So one can think of it as more of a sensory perception, which could be visual or auditory, tactile, or smell, olfactory, where someone has the sensation, if you will, of something that's there in the environment, but there's really nothing there of that modality, versus a thought disorder or thinking or believing that something's really true when it's not an actual belief. So,
We
good
received
point.
we received an email actually from a woman who's concerned about her parents, and it kind of fits into what we're discussing now. Her father has Parkinson's disease and has been experiencing what she believes is psychosis, depression, delusions, is what she said. His thoughts have sort of been obsessed with the idea that her mother has been cheating on him or unfaithful, and therefore this led to quite a toxic environment. And this sort of, again, illustrates what you described, raises a number of questions. First of all, this description of this family in crisis, is this a common presentation? Do you see this a lot in the clinic?
So I think you bring up a lot of great points with that situation. And while we can see people presenting in crisis, it is not always the most common presentation, but sometimes it's really the first presentation that gets to medical attention.
Mm-hmm.
And I think that's one of the reasons why it's so important to have education and awareness and webinars like this to talk about these symptoms and have people have them somewhere in their mindset to talk to their physician before it reaches that crisis point. As I said before, delusions such as paranoia, suspiciousness, infidelity are the more common ones that we see, but in the spectrum of psychosis, they represent a smaller percentage of psychosis.
So when you see a family like this, I'm sure you do, in the midst of sort of dealing with the psychosis or delusions, what are some of the challenges that you face? How do you approach this sort of problem, I guess?
Yeah, this can be a really challenging situation. And, we really try to, if we can, get to things before they hit that florid crisis point. So I think there are a couple of pointers there. And yes, it sounds like this family may be in that crisis situation, is that and there certainly can be a lot of family stress associated with this. So to think about what we can do first and foremost. So probably first and foremost, the safety of the person with Parkinson's and their care partner are paramount. So that may involve immediate medical attention. It may involve going to the emergency room. It may involve talking to the physician over the telephone or nurse over the telephone to figure out what is acutely going on in that situation. And from there, being able to take the situation, assess it, determine whether one needs additional medical workup for something that might be contributing to these new symptoms, and then management, which I hope we can talk a little bit more about in detail of how we approach that from intervention standpoints.
So you mentioned that there might be something medical that could be contributing to the situation. Do we know what causes psychosis in Parkinson's disease?
So we have a lot of ideas as to what contributes to psychosis in Parkinson's, and it may be a combination of a number of factors. So we know that medications can play a role. So dopaminergic medicines that we use to treat the motor and other symptoms of Parkinson's certainly can contribute and may be a tipping point for some patients. But they're not the only reason people can develop psychosis, and that informs our understanding of why people may develop hallucinations or delusions. And I think this ties in all the other elements of non-motor or neuropsychiatric symptoms that we're trying to approach during this webinar, because I think some of the theories about why people develop psychosis include changes in alertness or arousal or attention. So the brain may not be processing information coming in the same way. It may be why we see more hallucinations in the evening or nighttime when it's dark, or under low visual or other stimulation environments. We may see a relationship with sleep. So some people have hypothesized that hallucinations may represent dream intrusions while people are awake, or kind of acting out of their dreams in the awake state. And now that may be a little more simplified than the reality, it ties in some of the sleep and wakefulness elements with brain processing. Interestingly, there also can be elements of the visual system involved, all the way from the retina, the very front part of the eye, to the back part of the brain, the visual association cortices that help process visual information. And there may be some disconnect in how information gets processed visually, and changes in things like color perception or contrast of dark and light that all may play a role in the development of hallucinations.
Is there a certain point that someone could be more at risk in terms of getting psychosis within the realm of Parkinson's disease, certain attributing factors, or is it a matter of the timeline, later on in the disease is something more likely to happen? What do we know about that?
So we know that there are certain associated factors that may be linked in one way or another to the development of psychosis. And those have been studied over the years in a number of different studies, so large epidemiologic studies or smaller cohorts. And some of those that seem to be more consistent across multiple studies include things like older age or more advanced Parkinson's, having longer duration or having more motor severity. Mm-hmm. In addition, I think some patients who have greater cognitive impairment may have a higher risk or higher association with psychosis. And that lends to the situation where some people may keep their insight. So they know when they see a hallucination, it's not real. Whereas sometimes other people, particularly if they have a little bit more cognitive impairment, can't quite make that separation or differentiation. With that said, we know that psychosis doesn't affect all patients with Parkinson's, all people with Parkinson's, but yet something that we need to learn about why people become at higher risk.
And you mentioned just a couple of minutes ago about medications, that sometimes the high use of dopamine replacement could be an issue. Are there other medications for other, I guess, ailments, or maybe even over-the-counter medications that people should be aware of?
Certainly. And it really behooves us, not only as physicians, movement disorder neurologists like myself, healthcare providers, always to ask people what their medicines are. And not only their Parkinson's medicines, but those for other reasons, whether sleep or blood pressure or bladder control. It's really important to always have a complete list of those medicines. And on the flip side, it's really helpful when people come to appointments to have that medicine list, so we can continually review what those medicines are, what those doses are, what might be okay with having Parkinson's, and what might not be the best option with Parkinson's. So with that said, I think there are a number of medicines that we look out for that can contribute to not only psychosis, but cognitive impairment. Some of those include broad classes of medicines like anticholinergics, which sometimes can be used to treat tremor, sometimes can be components of different sleep medicines or different antidepressants like tricyclic antidepressants. We also look at medicines, sometimes certain bladder medicines can have effects that what we call cross the blood-brain barrier and get into the brain chemistry and neuron transmission, and can have some effects on cognition and hallucinations that we would not wish to have. And then certainly things like pain medicines or anything that really can be sedating and disturb our level of arousal and cognition.
What about other illnesses or infections? I know they can affect us in many ways in terms of our symptoms. Does this also play a role in psychosis?
It does, and particularly if someone has a new onset of psychosis, so the symptoms for the very first time or an escalation in the symptoms, so they might have been there a little bit, but all of a sudden or over a matter of days, they're much, much worse. It's really important to think about what else it could be. So sometimes it is related to the Parkinson's and the Parkinson's medicines, but it could be the sign that someone has an underlying medical condition. Probably the number one reason that happens is that someone's fighting an infection. Most commonly a urinary tract infection is probably the most common laboratory test we would order as neurologists for someone who has the acute development of psychosis or acute change in mental status. But I think it's important to think about other medical illnesses, whether it's a pneumonia or someone might have fallen, hit their head. There might be a reason to look at a brain scan and look at other medicines. So sometimes it's just the tipping point or the tipping balance of an increased dose in the medicine for Parkinson's, or someone perhaps who takes a medicine called amantadine that we use frequently in Parkinson's that gets involves the kidneys, and sometimes that level is just too much for one person. So really important to have that medical dialogue.
Right. So that's sort of the approach you would take in terms of a family such as we just described. But what advice would you have for the primary care partner and the family? Like, what at the time of the patient is experiencing those hallucinations and hallucinations or delusions, what in general how should they approach that?
Yeah, this is such a tricky situation sometimes to see someone's loved one or someone that one cares about in the midst of these situations. I think one take-home message is always to remember that these phenomena are really the underlying disease or illness or Parkinson's and not the person. So it's really related to something else that's going on and not the relationship directly, although of course it can impact that relationship. And it can be scary. It can be scary for both parties, the person who's experiencing it and the person who's watching their loved one who has Parkinson's experiencing it. I think I'm often asked, as you said, what should I do in this situation? How should I approach my loved one and interact with them? And every situation's different, every relationship is different, and sometimes one has to trust their gut and how well they know the person, whether it's their spouse or parent or child. But I think there may be a few general pearls of wisdom, and those include not trying to argue with someone and not trying to say pick a fight or anything that would agitate the situation more. So trying to have a calming environment or reassuring the person. And it's okay to acknowledge that reality of that person and, acknowledge that they may be seeing something, but you might not. And that's okay. It kind of gives validity to their experience, which is also an important aspect. I've had people, try to deal with this in many different ways, sometimes with reassurance, sometimes with some humor. Sometimes people have named their hallucination if it's a person who comes to the dinner table. Sometimes diverting attention and just switching gears to talk about something else or go look at something else is enough just to get the brain back in, a different groove, so to speak.
Right. Well, I think that gives, people sort of a toolbox of which ways to approach it. But I think one of the most important messages that you seem to be saying is that get help from your movement disorder specialist or your neurologist, because this is not something that you have to deal with on your own, and it's something that you could certainly rectify if the appropriate steps are taken.
Absolutely. And I think part of starting the conversation has to do with education and discussions, even from the earliest avenues. And when we think about it and we prescribe medicines that can have some of these side effects, it's really important for us as medical professionals to share that these could be occurrences, not that they necessarily will be occurrences, but something to keep in mind. I will say my patients know that I will ask at our routine visits about these types of symptoms, and that if something changes or they come about, we want to know. We want to know about it to try to see if we can nip it or change things before they escalate to that crisis point.
Right.
I think the other point is it takes, the saying, it takes a team, that this really does take not only movement disorder neurologists or neurologists, general neurologists in the community, but working with our nurses, our advanced practice providers, psychologists, psychiatrists, social workers, and so forth. So really all people can have their hands in this to help.
Well, just to sort of tie up that initial email that we received, I just got a message that it was apparently a medication that was probably causing that acute crisis situation in that family. So again, that's good to know. Hopefully they can.
And if I can add just a comment on that, one of the things that we need to do when we approach the situation, so we talked about eliminating or excluding other medical issues, but we may need to adjust the Parkinson's medicines. We may need to lower different doses. We might even need to discontinue some of them and balance that mental function with the motor function. And then sometimes we might need to introduce other medicines to help treat the psychosis symptoms. So I think all those may play a role, potential role.
Right. I'd like to go on to our next email that we got, if that's okay, Dr. Goldman. And this is about, this is from a woman whose husband, she's worried about him. She wants to know, she says that she can be sitting next to her husband and having a conversation, and she'll stop for a moment and then say something else. And he totally ignores the fact that she's speaking again. He does wear hearing aids, but even when they're on, it seems she has to sort of poke him, to prod him, to say multiple things to get his attention. Feels his mind is drifting, and then he has a great deal of difficulty grasping ideas and concepts and following conversations, which is leading to his isolation, unfortunately. And she wants to know, is this an early sign of Parkinson's dementia? He's very, very forgetful, and he doesn't remember any instructions. So I guess before we get into the specifics of that particular situation, we could maybe discuss a little bit more, sort of a little review from our last webinar, but what we're talking about when we use the term cognitive decline.
Sure. So, cognition, broadly speaking, has to do with our ability to think and process, take in the world around us, take in knowledge, and be able to understand that and use that as communication or making decisions and planning and so forth. So we do see that some patients, again, not every patient will experience all the things we're talking about in these webinars, but that some people with Parkinson's can have some changes in their cognition. And you highlight a number of different elements in that scenario that you just mentioned. So some of those more common scenarios that we see in Parkinson's affecting cognition can include changes in attention or concentration. They can include changes in what we call executive function, which is really our ability to plan and process, organize our thoughts, shift from one topic to another, and kind of keep things also in our head, with a term we use called working memory. And then other elements that may impact someone's communication. So finding the right words to say, forgetfulness you mentioned in that scenario. And then sometimes elements that have to do with sense of direction or navigating around in space, sort of our visual spatial abilities. And all those can play a role in cognition or cognitive changes. Sometimes when we see them in Parkinson's, they can be mild. So just kind of like slower processing, the way movements can be slower, thinking can be slower, or it's harder to extract that information. We know it's there, but it takes a longer time to come out, to more severe changes in cognition that may affect multiple areas and may impact someone's ability to do day-to-day tasks. And that's when we talk about dementia.
Right. Is this scenarios consistent with what you see? I mean, do these things come to your attention via the patient usually, or via the patient, the partner, the care partner?
It depends. It may be a combination of both, or it may be one or the other. One important aspect when thinking about cognition or assessing people for cognition is it's important to evaluate it in a number of different ways. So not only what a person with Parkinson's might say about their thinking and memory or their cognitive abilities, but also some sort of objective opinion, which could be a spouse or a friend or a child. We often call them the informants. So some sort of objective corroboration, if you will. And then also having objective tests. So we may do those as neurologists. We may work with neuropsychologists, psychologists, or allied health therapists who may administer what we call other objective evidence of cognitive changes. So it really depends. I think some people notice these changes themselves, and that may be slower thinking or processing, or the tip of the tongue, finding the right words. But sometimes they're noticed by the care partner and less so by the patient, or vice versa.
Right. Yeah, you're right. I'm sure it's very individualized depending on the situation and how perhaps good at the patient is hiding things, and the care partner for being astute and recognizing it. But there must be a period of time where it's very difficult for either one to as the process begins. But once you sort of have somebody in your office and you diagnose them with maybe mild cognitive impairment, or if you suspect early dementia, what are some of the practical things that you tell patients and their care partners or their family that they can do, that they should do?
Mm-hmm. And certainly. I think a couple key pointers. One is we've touched upon is really getting attention and having this conversation with medical professionals to understand if this is the diagnosis, what it looks like, how do we come to that diagnosis, and then what can we do about it? And there are a few things that we think about. So one being looking at medicines or looking at factors that may be contributing to cognitive changes. So sometimes we need to eliminate medicines rather than add them. I think it's also important too to take a look at how someone's sleeping and how their mood is, because those can play a role in cognition as well. So I think we've all probably experienced how we feel after not sleeping for a night or a few nights in a row and just feeling like our brain is not functioning the way we would like it to. So sometimes thinking about sleep and improving sleep hygiene and sleep function can play a role in cognition. We also know, and really in part of the focus of this webinar is how cognition and other areas of non-motor features tie in together, is that things like depression and anxiety may play a role in cognition and cognitive impairment. And so before going down the path that someone has mild cognitive impairment or MCI or dementia diagnostically, it's also important to assess their mood and other factors that might be contributing to the thinking and memory observations. I think the other third point, always thinking about what can we modify? What are our risk factors or things that we can control? So we know that there may be some links between other medical comorbidities like high blood pressure, diabetes, cholesterol, other elements that can contribute to cognitive impairment in general, and can also occur in someone in Parkinson's. So taking control of those risk factors and trying to minimize any of their effects. And then I think staying active. So here comes the more proactive part, in addition to taking stock of what we can assess and modify. So there's growing evidence for physical exercise, not only helping motor function, mood, cognitive abilities. So getting out there and doing something physical is very important. We also have a growing body of studies looking at cognitive exercises, which come in all sorts of sizes and shapes, and computers, pen and paper, all sorts of things that, I think we probably do need some more studies, but the old adage of, if you don't use it, you lose it. So keeping yourself stimulated mentally is really important, and doesn't have to be word games. It could be reading, it could be socializing. All those aspects are really important to brain health and cognitive health.
Anything else that you know that can help patients with their cognitive health? You mentioned exercise and cognitive exercise as well, but
yeah, and I think we're learning more about what we call, non-pharmacologic modalities. So physical exercise, cognitive training, cognitive exercise, learning even compensatory strategies. So how to, use mnemonics, or how to use even technology to help remember and engage in different elements. There's also a growing literature looking at nutrition, and I know that's the topic in one of the upcoming webinars, but is there a role for things like Mediterranean diet or other certain types of foods and brain health? And then lastly, one element that we haven't touched upon is really the use of medications. So are there medicines that we would think about to treat dementia and Parkinson's or other mild cognitive symptoms?
And what could you tell me in terms of advice for care partners and their families when they're faced with a loved one that may be embarking on some cognitive decline?
Yeah, I think it's important to recognize the symptoms and the changes, but also to recognize that there are still many things that we can do. So not only what I mentioned in terms of physical exercise, cognitive exercise, modifiable medical risk factors, but talking to one's physician about even some of the cognitive medicines that we know have been either approved for Alzheimer's or approved rivastigmine for Parkinson's dementia, participating in research trials for cognitive changes. And then really, I think there's a whole host of things that we could talk about in terms of interpersonal engagement and ways to either compensate or deal with or cope with the cognitive changes. And some of those practical items or practical pearls are things like not multitasking. So when someone's having a conversation, that's what they're focused on. So not necessarily walking and talking or eating and talking at the same time, but really, having a singular focus. It's important for people to speak slowly and have patience, both on the receiving end of the conversation. And often people with Parkinson's who have cognitive changes may respond better when they're given choices. So rather than, a wide open-ended question, being more specific or more direct and providing choices or cues. And there are a lot of strategies that can be used. From a family perspective, care partners, when therapists like physical therapists or occupational therapists, speech therapists work with people with Parkinson's, often they're very geared to cueing and what someone responds to and how to strategize that for different levels of cognition. So giving choices, one thing at a time, good eye contact, speaking slowly, many of those go a long way.
And I think it's like most things in this disease, a team approach is probably the best way to manage it. So you mentioned physio and OT. Any other allied healthcare professionals that could be a benefit to a family that's in this situation?
Yeah, so really, the team approach, people can work on different elements of cognition. So, and in fact, actually every member of the team to some degree will touch on cognition. So whether it's from the physician end, nurse, advanced practice provider, social workers can be instrumental, not only for the person with Parkinson's, but the care partner and the family dynamic and coping with stress and change. Psychologists or neuropsychologists may not only help in assessment, but also in treatment of some of the changes. And then really all allied therapy disciplines, PT, OT, and speech work on different elements of cognition, just in different ways. So walking and talking or balancing, occupational therapy for everyday activities around the home, in what we call instrumental activities of daily living, bills, shopping, driving, many things, as well as speech for communication.
Right. I just want to go back to one thing you mentioned, because I think, I mean, it is the title of the webinar, Cognition, How It Intersects with Other Non-Motor Symptoms. As a patient who has lived with this disease for as long as I have, I really do know that each motor symptom and non-motor symptom sort of affect and influence each other in terms of how you feel overall. So sometimes it's not necessarily even a matter of your disease progressing, but maybe something else you can optimize in terms of your variables will help with what you feel is worsening. My tremor, for example, is worse with my fatigue. If I get better sleep, my tremor is better. My dystonia worsens my gait and balance, for example. So therefore, if I can help my dystonia with medications or less stress or whatever caused that to happen, it will improve my gait and balance. So it's all about managing a variety of symptoms. But some motor and non-motor symptoms, I think, like cognition, really seem to have a more of a greater global impact on our overall life experience and kind of worsen symptoms to a greater degree than others may. Do you think that's so for cognition? Or do you think how do you feel about that sort of interplay between symptoms and how to approach that?
Mm-hmm. It's hard to take some of these symptoms and look at them in just isolation. Really, in the context of Parkinson's, they all may play a role in some form or fashion at different times in someone's life, in different types of severity, in different types of situations. So on one hand, it's almost hard to talk about cognition in a vacuum outside of these other components because we know they're related. We know motor symptoms can go hand in hand with cognitive symptoms and changes over time. We know that mood symptoms can affect motor symptoms. So, tremor's worse when people are anxious or stressed or fatigued. So again, I think they have this constellation and this very intricate relationship with each other. And they're kind of these fundamental truths. So I think that's why cognition plays a prominent role. So we move, we think, we sleep, we eat. So I think there's some really fundamental elements of our existence, and that may be part of why cognition comes up at the forefront for that.
Yes, I mean, I think you're right. The interplay between all these symptoms kind of adds to the complexity of the disease, which then supports the need for us as patients to really be active participants and kind of taking over control of the variables that we do have control over, and in order to optimize quality of life. I don't want to run out of time. We're going to go through some questions that I've been receiving online, but I first want to talk about the care partners in general, because I think, when we are diagnosed with a disease like Parkinson's, its impact doesn't stop with us alone. Our whole family and those that are important to us are affected. And without doubt, our physical symptoms can be hard to deal with for ourselves or our care partners, but cognitive and mood issues can be particularly difficult and stressful to handle. It can be exhausting physically and emotionally. And speaking of old adages, they say you can't look after anyone else unless you look after yourself. So what advice would you have for those that are experiencing that kind of care partner stress?
Yeah, I think, this is an area, particularly when there are cognitive or neuropsychiatric issues at play, that can be just additive on top of the motor symptoms, and juggling both of them at the same time can be very stressful. And I think the other piece, talking about these issues and being as candid as we are in some of these forums like this webinar, is that these can be really scary topics to talk about, and loaded with stigma and loaded with just a lot of elements to them. So it's important for care partners to take care of themselves. I know it's always sometimes easier said than done, but I mean, that really does mean, having some time for themselves as best as they can and carving that out, getting good sleep, getting exercise for themselves, taking care of their medical health and not neglecting it, which sometimes we see, and having their own team. So the many people I've seen who've been very successful in navigating this have really developed their care partner team. And that could mean anything from support groups, friends, family, neighbors, counselors, people in their religious affiliation, to expand their network of people they can call on and to help and give them support. So I think that's also a really important aspect. And there are many different ways people can do that and draw on different resources that are available. I think, one other element, is trying to take in the good and look towards someone's strengths and abilities and know that, every day sometimes can be a little bit different. And there are challenges one day has that the next day might not. So keeping that positive aspect and hope, I think can go a long way. So sometimes just even remembering, taking the joy in the littlest things that someone can do and appreciate, and doing that together.
Absolutely.
I think I'm always amazed too at the stories I hear from care partners that talk about even positive aspects of caregiving. So I know we talk a lot about the stress and the burden, which are very real, but also that people talk about positive elements or how it might bring them closer to someone in a way that they didn't appreciate before, and new networks of friends and things. So I think we also need to embrace that as well.
Right. And you're absolutely right. There's some joy in serving for sure, and to helping someone that you love. I just want to take a moment at this point in time to really give a big thanks to the people that take this journey with us in our lives, the care partners, because I've often said that it's much easier for me to bear the disease effects of this disease than to witness them in someone that I love. So I think it takes a very special and dedicated and wonderful person to stand by us through the ups and downs that this disease can bring. So thank you to all the care partners out there. Dr. Goldman, there's a couple of questions I thought I want to get to, if that's okay with you, from our viewers today. And one person asked the use of estrogen with regard to cognitive issues. She thought she heard that there was a study that just came out that's saying estrogen could be helpful.
So there's an interesting relationship between estrogen and dopamine, and estrogen and Parkinson's, that we probably don't fully understand, but there are some elements associated between the two. Whether or not that plays a role in cognition, I think, remains to be seen. There's been a lot of literature outside of Parkinson's talking about hormonal influences and estrogen, in women as they age, go through menopause, and may have cognitive changes. And that still has some controversy in the world and literature. But it's a really interesting thought, as we start thinking outside of our usual neurotransmitters, so our usual dopamine system or the other brain chemicals we talk about, and how other elements, whether hormonal or immune or inflammatory, some of these other elements might play a role in Parkinson's, perhaps, and might play a role in future treatments down the road after future study.
It's interesting.
Mm-hmm.
Another viewer has asked what your knowledge is of cognitive impairment due to neurogenic orthostatic hypotension. So I guess a drop in blood pressure. Is there any connection, I guess, between the two?
Mm-hmm. So I think the person was commenting or asking about what we call orthostatic hypotension, which means that there's a drop in blood pressure, typically when someone either goes from being flat, supine, to sitting, to up to standing, to a certain degree that we measure. Some people can experience that as lightheadedness or feeling weak or feeling faint. And I do think that there are some people who can experience that as being foggy or kind of brain freezing up, if you will. I think we know one thing that makes sense, that we need blood flow and circulation up to our brain in order to nourish it and have good brain function. So interestingly, there have been a few studies coming out in the literature looking at the relationship in a chronic situation, so over long-standing Parkinson's. And I think we see that both cognitive changes and what we call autonomic symptoms, so orthostatic hypotension being one, are more common together and more common as the disease advances. Mm-hmm. The other is that there have been some studies looking at measuring cognition, doing cognitive tasks with people in different positions, from sitting and standing, and that there may be some measurable changes in how people perform on some of those cognitive tests that we typically do when someone's seated in a neuropsychological exam or with a neurologist. So it's important to address, and there are a number of non-pharmacologic ways and medicines and adjustments to address those blood pressure drops.
It's interesting. Everything's so interrelated. Another viewer is asking if one with young onset Parkinson's disease is experiencing occasional hallucinations, is that likely to develop into more serious hallucinations or delusions in the future?
So I think that question may have two parts to it. One is the element of age or young onset Parkinson's, and then what we know about the progression of different hallucinations and psychosis across the spectrum. And so just broadly speaking about that, we do know that many people have what we call either minor hallucinations or more milder hallucinations that can stay mild and do not necessarily progress methodically from illusions to hallucinations to delusions. In fact, delusions, as I mentioned earlier, are really a rarer, smaller subset of psychosis. So sometimes we do see there's a progression across or the gradation of the spectrum, but not always. So many people who have hallucinations may have hallucinations. They may have visual, they may also have multimodal visual plus auditory at different stages. I think the other piece is the age and the young onset question. And, while we typically think of psychosis as associated with more older age as one of its linked factors, so there's an association between that, which may or may not apply to someone who's young. But I think sometimes younger people are on more medication and higher levels of dopamine medicines or certain classes of dopamine drugs, such as dopamine agonists or anticholinergics. And so all that could potentially play a role. So I guess there's no short answer to that. Slightly more complicated.
Well, like everything else in Parkinson's disease, it's complicated. Someone's asking what cognitive exercises, when you discussed cognitive exercises, do you have any examples of what you mean or what you would recommend?
Sure. So, this is an area in evolution. And so there's not one prescriptive exercise that we can, give our stamp of approval on the way, the FDA does for medication. But there have been a number that have been studied in various trials and a number anecdotally. And those can involve anything from word games, things like Sudoku, things like computer programming, programs that are available, video games. And what they try to do is they tap into different elements of cognition. So we spoke briefly early in the webinar about some of the cognitive areas or cognitive domains. So many of these games or exercises try to tap into attention, improving concentration, improving what we call working memory or even verbal fluency, like how many words with the letter S can you name, or how many animals or things that have to do with category and letter fluency, looking at different visual spatial patterns, looking at memory. And so all those probably play a role in enhancing one's cognitive performance. I think some of the things we don't know in the field, and we need to study more, is do they generalize to other skills? So if you improve executive function, will you also improve memory? And will it last? So if you play Sudoku 3 times a week for the next 6 weeks and then you stop, will it carry over, and will it help one a year from now? And so I think there are a lot of things we just don't fully know, but certainly could study more.
I guess the thing would be to do things consistently and things that you enjoy and will actually do.
Absolutely.
So as we start to wrap up, Dr. Goldman, I'd like to ask you for some parting advice. There's a lot of apprehension on the part of those of us with Parkinson's disease regarding non-motor symptoms of mood disorders and cognition. And are there any words of advice that you would have that might help mitigate that fear?
Yeah, and I know these are often not easy topics to talk about, and certainly can be scary and frightening, and probably even anxiety provoking. So I think there are a couple key things to remember. Is one, although we've talked about a lot of different symptoms, not only in this webinar, but in Dr. Weintraub's and other webinars, that while some people may experience these symptoms in their journey with Parkinson's, not everyone does. And Parkinson's can be so individualized in its motor symptoms, it can be just as individualized in its non-motor symptoms. So I think that's definitely one important takeaway. Another is that with education and discussion, I hope that we can see that this can actually be empowering to people with Parkinson's and their families and care partners. So knowing that this may not be an occurrence, but if it is, there's help and there's medical attention, there's lots of things that we can do. And we want to start that conversation early. And we want to repeatedly ask about it or regularly check in about these symptoms. And it could be reassuring and say, we check in and we say, you know what, all things are good. We'll follow up again in a couple months, and if something changes, to let us know. And I think the third takeaway from this is that there's a lot of reason to have hope. There are more and more studies going on in non-motor and neuropsychiatric elements of Parkinson's than really ever before. So, I mean, for many years in my career, we did not have these trials. We did not have medications with approval for different neuropsychiatric issues or clinical trials looking at medicines or surgical therapies, neuromodulatory therapies, and non-pharmacologic interventions. And this is a space that's really just only growing and growing. So I think that will resound to benefit.
Absolutely. And I think that can be accomplished, the sort of approach can be accomplished with people that come to, say, your clinic. But there's one question I have that has been asked, and I think it's relevant for many of our viewers today, and that's, what about people that don't have access to an MDS or a neurologist and sort of see their primary care physician, and how can they advocate for themselves in that situation? What can they do? Are there online resources, or what do they ask for when they're experiencing this?
And we know that, as you said, not everyone has direct access, but it is something I think we're working on and trying to train more people, get them interested in the field so they can go on and become movement disorder specialists. But there are a number of ways to advocate for oneself. And part of that's, I think, education and awareness, and even people who, if they don't see a movement disorder neurologist, but may have seen this webinar, to bring some of these elements to their primary care, to their general neurologist, to help bridge some of that gap. There are a lot of online resources. There are a lot of in-person resources. Some of those might be support groups. They can be online virtual support groups. They can be foundations like yourself and other Parkinson's foundations that really have lots of tools and resources for people living with Parkinson's. And sometimes we even borrow from other conditions that focus more on cognition, like Alzheimer's, and sometimes their resources can be pertinent, even if it's a different condition. And so I think having a lot of tools in one's toolbox, as you said before, are ways to empower someone. I think there's also growing work being done in community outreach and things like telemedicine and being able to access physicians or healthcare providers who may not be physically located in the same catchment area. So I think there's still work to be done, but a lot of ways to spread the knowledge and access to care.
Thank you so much. So we're coming to the end of our time together. Dr. Goldman, I thank you so much for your insight and expert advice. It was so greatly appreciated. And thank you to everyone else for joining us today. I hope you found your time, as I did, with us helpful and educational. And we'll be sending you a link for the recording of this webinar in the next few days so that you can share it with others. And always remember, you may not have control over your diagnosis, but how you face the diagnosis is really yours to determine. So focus on optimizing your quality of life, educate yourself, empower yourself, and celebrate your daily victories. Thank you very much.